We are presenting video case series entitled Endoscopic Management of Magnet Ingestion in Children. These are disclosures. These are keywords. Foreign body ingestion is common in children. Magnet ingestion in children has increased in the last 5 years as the use of magnet in toys has grown substantially. Multiple magnet ingestion can be hazardous and can lead to adverse events like a perforation, fistula formation and bleeding because of pressure necrosis of the trapped bowel wall. Better awareness of the hazardous effect of magnet is needed amongst healthcare professionals, parents and children. Case first. A 4-year-old female presented with abdominal pain for 10 days. On fluoroscopy, two round radio-opaque objects were seen in the epigastric region. Parents gave history of child ingesting magnets around 30 days ago, but they were waiting for spontaneous passage of magnets. She underwent endoscopy under propofol sedation. Gastroscopy showed one round-shaped magnet adhering and penetrating through the gastric mucosa on lesser curvature. Gastric magnet was grasped into Rothnet and with gentle traction it was dislodged from gastric mucosa and then retrieved out of the body. After removal, full thickness defect was noted in gastric mucosa at the magnet site. Gastroscope was then passed into duodenal bulb where another magnet was located. Second magnet was seen to be dislodged from adherent site because of absence of magnetism after first magnet removal. The second magnet from duodenum was removed with Rothnet. There was full thickness defect seen on anterior wall of duodenal bulb. Pressure necrosis by both the magnet in stomach and duodenal bulb have caused full thickness defect both in gastric as well as duodenal mucosa respectively. Both gastric and duodenal defect was then closed with through the scope clips. Post-procedure patient was stable. She was hospitalized for 1 day and given intravenous antibiotic, proton pump inhibitor therapy and fluids. On day 2, she was given liquid diet and discharged on oral antibiotic and PPI. Repeat gastroscopy after 1.5 years showed normal examination. Case 2. A 7-year-old male presented with mild abdominal pain for 2 weeks. On fluoroscopy, two bullet-shaped radio-opaque objects were seen adjacent to each other in umbilical region. On inquiry, he gave history of magnet ingestion 3 months ago, but he did not reveal it to anyone because of fear. He underwent gastroscopy under propofol sedation. Scope was pushed deep down into third and fourth part of duodenum, where bullet-shaped magnet was seen adherent to the duodenal mucosa. Magnet was grasped into Rothnet and dislodged from mucosal site with a gentle traction, and after dislodgement it was removed out of the body. Gastroscope was passed again in search of second magnet. There was a large duodenojejunal fistula seen at the first magnet site. Scope was advanced through fistula's opening into jejunum to locate second magnet. Even after deep insertion into jejunum, second magnet was not found as it was dislodged deep into small bowel. Endoscopic removal of magnet was advised. However, his parents did not give consent for the same. Duodenojejunal fistula closure was not done as it was looking in a tight and well opposed state. Post-procedure patient was stable. He was discharged on request. Parents were asked to monitor and inform about the passage of magnet in stool. After 36 hours, magnet was noticed in stool. On telephonic call after 8 months, parents reported that he was doing well and had also gained weight. Case 3. A 5-year-old male had magnet injection 2 days ago. He was complaining of abdominal pain for 1 day. On fluoroscopy, two small radio-opaque objects were seen in upper abdomen. Because of lack of infrastructure at local place, he was referred for endoscopic removal of magnets. He underwent gastroscopy under propofol sedation. Gastroscopy showed one magnet in a duodenal bulb adherent to anterior-superior wall of bulb. First magnet was grasped with a Rothnet and dislodged from duodenal mucosa. During dislodgement of magnet, mild bleeding was noted. After first magnet removal, scope was passed again into duodenum in search of second magnet. Scope was inserted deep into third and fourth part of duodenum. However, second magnet could not be located. On slow withdrawal, fistulous opening was noticed in superior wall of duodenal bulb at the site of first magnet. Scope was then advanced through fistulous opening where second magnet was seen in the jejunal loop. Second magnet then grasped into Rothnet and removed. Duodenojejunal fistula closure was not done as it was looking in a tight and well opposed state. Post procedure, he was hospitalized for 2 days. He was kept nil per orally and given IV antibiotic, PPI and fluids. On day 2, liquid diet was given under supervision. On day 3, he was discharged on oral antibiotic and PPI. At 2 weeks of follow-up, he was asymptomatic and taking normal diet. To summarize, case first with gastroduodenal fistula underwent fistula closure because gastroduodenal fistula was not looking in tight and well opposed state as compared to case 2 and case 3 where duodenojejunal fistula was in a well opposed state. To conclude, urgent removal is warranted for multiple magnet ingestion to prevent its adverse events. Endoscopic removal of magnet is safe and effective in children. In selected cases, magnet-related fistula in tight and well opposed state can be managed conservatively. There is an unmet need to increase awareness in the society about magnet ingestion and its adverse events.